Good morning, everybody. Myself, Dr. Varsha Japshetty, Associate Professor, HKES'S NIJALINGAPPA Institute of Dental Sciences and Research, Kalaburagi. First and foremost, I would like to thank Indian Prosthodontic Society, Karnataka State Branch for giving me this opportunity to be a speaker for this virtual masterclass, PROSTHONEXUS 2025. I would also like to show my heartfelt gratitude to our department head, Dr. Arvind Muldi sir, for giving me the opportunity to represent our college as a speaker. Today, I will taking you through the topic materials and retentive aids in maxillofacial prosthodontics and will be discussing the key concept, relevance and application. I hope by end of the session you will have a clearer understanding of the topic. Firstly, we will like to discuss the materials for maxillofacial prosthetics. The content is introduction, historical background, classification, desirable properties, different materials, summary, and the references. Introduction. It is a God-given right of every human being to appear human. According to GPT-9, any prosthesis used to replace part or all of any stomatognathing and or all craniofacial structures is known as a maxillofacial prosthesis. In the review of literature, in 1510, Ambrose Paré appeared to have been the first to fabricate nasal and auricular prostheses using gold, silver, paper, and linen cloth glued together. In 1546, the Tycho Brahe used an artificial nose made from gold to replace his own nose. Perry Fauchard, in 1678, the father of modern scientific dentistry, fabricated a silver mask and painted with a oil paint. Dr. William Morton in 1819, who is famous for developing anesthetics, fabricated a nasal prosthesis out of porcelain and enameled it to the exact color of the patient's face. While in 1859, the Charles Goodyear, he discovered the vulcanized rubber, while in 1901, Upham, a Boston dentist, described the use of vulcanized rubber to fabricate a facial prosthesis. Following the use of this pre-vulcanized latex in 1930s, the acrylic resin became available to the dental profession in the early 1940s. In 1960, silicone was developed by Dow Corning Company. George Barnhart, a maxillofacial technician, introduced the silicones to the field of maxillofacial prosthodontics. In 1970, the Gonzalez described the use of polyurethane. In 1970s to 1990, the launch that is modified the polysilicon elastomers, while Udgama and Drain, the elastic medical adhesive type A, he discovered it. While 1990 till present, the Antogoni and Stansberry new generational acrylic resin was developed by them. While the polyphosphazine, that is a recent advances, nowadays we are using it, is discovered by the gentleman. The classification for the maxillofacial prosthodontics, according to the impression materials, it is plaster of Paris, plaster bandage, elastomeric impression material, irreversible hydrocolloids. According to the fabrication materials, we can use the acrylic resins, polyvinyl polymers, polyurethane elastomers, and silicone elastomers. According to the pigmentation material, those are the intrinsic and the extrinsic pigmentation materials. According to the retention materials, we can use the primers, adhesives, implants, and magnets. According to the different authors, according to Bumer, we can use the acrylic resins, acrylic copolymers, polyvinyl chloride, and copolymers. While even we can use a chlorinated polyethylene, polyurethane elastomers, silicone elastomers, that is the HTV and RTV foaming silicones, and newer materials like a silicone block copolymers and polyphosphazines. According to Anusa Weiss, we can use a latex, which is a tripolymer of a butyl acrylate, methyl methacrylate, and methyl methacrylamide, vinyl vinyl plastisols, silicone rubbers, and polyurethane polymers. Desirable properties, the materials which should have is the physical and mechanical property, biological property, fabrication property, and aesthetic properties. Now we will see one by one. In the physical and mechanical property, the material should have a tear strength. The tear strength, it means the resistance of a material to tearing of force and is important in thin sections such as the area surrounding the nasal and eye prosthesis. It is generally measured by the pants tear energy, where a thin sheet of elastomer is made in the shape of a pair of pants. The legs of the pants are then pulled slowly apart and the energy required to propagate a tear is measured. The strength should preferably be 30 to 100 pascals, 53 to 137 Newton per centimeter to resist the rupture at the edge for a daily use. The ultimate tensile strength and percentage elongation, which means the total percent elongation, which includes the both elastic and plastic elongation, is useful as different parts of the face have different requirement in terms of stretching the elastomers to accommodate the facial movements. The tensile strength should be 300 to 1000 psi. The dynamic modulus. The dynamic modulus is defined as the ratio of a stress to strain for small cyclical deformations at a given frequency and a particular point on the stress strain curve. For the maxillofacial materials, it should be flexible in nature, that it should have a less dynamic modulus. The hardness. Hardness, it means the resistance to abrasion, while the it should be soft, having a hardness of less than 40, preferably in the range of 25 to 35 Shore scale, and resilient enough to respond to a facial motion. Stiffness, it means the material should also possess a low glass transition temperature in order to prevent the stiffening of material when exposed to cold temperature. Weight, the materials always for the maxillofacial prosthesis, it should be light-weighted so that they are compatible or comfortable for the patients and aid in the retention of the prosthesis. The physical and mechanical properties, in short, the dynamic properties comparable to the tissues. It should not be low resistance, that is, it should be high resistance to abrasion. It should have a high tear strength, low glass transition temperature, low specific gravity, low surface tension, low thermal conductivity. It should be odorless, non-inflammable, non-water absorption, soft, compatible to the tissues. In the biological property, the material should be compatible with the supporting tissues, whether we are using it for the face or we are using it for the orbital prosthesis, nasal prosthesis, or ear prosthesis. It should be non-allergic, non-toxic. The material should be easy to cleanse, cleansable with the disinfectant. It should be color stable, dimensionally stable, and flexible enough comparable to the tissues. The flexibility stable at the extremes of a temperature is very important, where inert to solvents and skin adhesives. Resistance to environmental discoloration, resistance to growth of microorganisms, and softness maintained during the use. The fabrication properties. It should be ease of mold fabrication, easily for the processing, dimensionally stable, ease for the intrinsic and extrinsic coloring. It should be color stable, chemically inert after processing, and non-porous after processing. In aesthetic point of view, it should represent the finest details of lost structure. Color, texture, form, and translucency must duplicate that of missing structure and adjacent skin. According to the different materials, we can use the acrylic resin, polyvinyl polymers, polyurethane elastomers, and silicone elastomers. First, we will discuss about the acrylic resin. Mainly, the acrylic resins, we are supposed to use it for the facial defects where the movements are restricted, that is ocular defect. The advantage of this material is that it is inexpensive, ease of fabrication, both an intrinsic and extrinsic coloration is possible, compatible with the most adhesive systems, easily repaired and relined with the soft conditioner. While the disadvantage is that this material is very rigid and the surface deterioration after some time is more, while the higher thermal conductivity is also there. After that, we can see the acrylic copolymers. It consists of esters of acrylic and methacrylic acid. The prosthesis has a sponge-like center and continuous skin-like covering. Advantage is that it is soft and elastic, while the disadvantage is that it is poor edge strength, degrade in sunlight, processing and coloration is difficult, and gets stained easily. Polyvinyl polymers. It is the material which is most widely used, which is composed of a vinyl chloride and vinyl acetate, is more flexible and resistant to sunlight. Polyvinyl chloride, it is clear, hard resin heat, tasteless and odorless, darkened when exposed to sunlight, while the polyvinyl acetate is resistant to light and having a low softening point. The advantage of this material is that it is flexible, intrinsic and extrinsic coloration can be done, while the disadvantage is that it is plasticizer, migration and loss, edges tear easily stained and poor dimensional stability. Chlorinated polyethylene. The processing involves the high heat curing pigmented sheets in metal molds. While Dow Chemicals chlorinated polyethylene elastomer is an industrial grade thermoplastic elastomer. It is less irritating to the mucosa than silicone, less toxic than the thermosetting silicone materials, and non-carcinogenic. While the chlorinated polyethylene elastomer appears to be a suitable substitute for silicones for the fabrication of extraoral maxillofacial prosthesis in situations where cost of silicone is prohibitive. Polyurethane elastomer, it is also called as a isocyanate or urethanes. This material is chemically composed of an extended segment of aliphatic diisonate groups and a segment of polyol groups, a mixture of polyesters and an organotin catalyst for the polymerization process to occur. The advantage of this material is that the patient acceptance is good, it is elastic in nature, flexible, ease of coloration is there, environmentally stable, high tear resistance, and low modulus without use of plasticizers. And the disadvantage of this material is that it is poor compatible with the adhesive systems, difficult in cleansing adhesive from the prosthesis, durability is less than 6 months, moisture sensitive, locally irritative, and the skin irritation is also seen. The silicone elastomers, it is first use of the silicone for the facial prosthesis which is given by Barnhart in 1960. He used the polydimethyl siloxane, synthetic copolymers containing of a silicone, oxygen atom and organic group. Most widely used materials for restoring facial defects. The silicones is again divided into the basic type and the application. The basic type is again divided into the room temperature vulcanizing silicones, which is also known as RTV, and the heat temperature vulcanizing silicones, that is HTV. The application, according to it, it is again divided into the medical grade and the industrial grade. They use more often than any other type of materials. It has a good physical and mechanical properties. Vinyl and hydride containing siloxanes, chloroplatinic acid, which is used as a catalyst, and tetraethoxysilane as a cross-linking agent. In that, we can see the Silastic 382, 399, MDX 44210, Silastic 899, that is Silastic Medical Adhesive Silicone Type A, Cosmesil or Silskin 2 System 82186 Factor 2. Room temperature vulcanizing silicone, that is RTV. These are again is divided into the two types, that is a cross-linking by condensation reaction and cross-linking by addition reaction. The cross-linking by the condensation reaction, they have a reactive group such as a silariose, that is hydroxyl terminated polysiloxane. This method of cross-linking requires a cross-linking agent, that is example is a tetraethyl silicate and a catalyst, that is dibutylene dilaureate. The disadvantage of this material is that it produces a byproduct and curing time is excessively long, making it impractical for curing the material inside a mold. Degradation reactions such as a hydrolysis is also can seen the relatively low tear strength and incapable of maintaining the edge resistance. While the second type is by using the addition reaction, where we are involving the silyl hydride and the vinyl groups, which are, because of the addition of these two groups, we can use aid in the platinum containing catalyst. And because of that, not truly is a true vulcanized silicones. The curing of this silicone in fact requires a heating the material at 150 degrees Celsius for a time, possibly an hour. These materials have improved tear strength over the first type of RTV silicones. Room temperature curing silicones are supplied as a single component material that cure by evaporation of acetic acid. They are characterized by a natural flesh-like appearance by use dyed rayon fibers, dry earth pigments, and/or oil paints. Processes are polymerized by bulk multiple packing. The Silastic 382 and 299, which contains the stannous octet catalyst and orthoalkyl silicate as a cross-linking agent. The advantage of this material is it is color stable, clear solutions, easy to process, require stone molds, while the disadvantage is that it has a poor strength, difficult color, and the cosmetic results are very inferior. MDX 44210, it has a chloroplatinic acid catalyst and hydromethyl siloxane as a cross-linking agent. The curing time is 80 degrees Celsius for a 1 hour. Murray reported improved properties, and advantage of this material is it has the no reaction byproduct, that is the addition reaction occurs, increase the elongation, it is non-toxic, color stable, simple processing, and compatible with the adhesives. Silastic 891, it was discovered by the Udgama and Grain, which is a translucent, non-flowing and polymerizes in air. In 1987, the Udgama used it along with the polyurethane film to improve its edge strength. The advantage of this material, it has no need of a mold, no catalyst, and compatible with the wide range of the colorants. The Cosmesil, it is again divided into the two types, that is a platinum cure and the tin cure. The platinum cure, where it utilizes the vinyl terminated silicone and a platinum catalyst. It is an addition reaction, so no byproduct is seen and hence no shrinkage can occur. The working time is 1 hour and curing at 100 degrees Celsius for 1 hour. While the tin cure, it utilizes the hydroxy terminated silicone fluids and tin catalyst, the condensation reaction, so that there is no byproduct is formed. It is very robust and cures against most substrate and conditions. The working time is 1 hour and cures in 24 hours at a room temperature. A211886, that is factor 2, recently developed material, initially showed improved properties, but Hogg reported that it doesn't retain them when subjected to environmental variables. Two types of curing system similar to the Cosmesil, that is the platinum and the tin cure. Again, we will shift to the heat cure vulcanizing silicone. It is a polymethyl vinyl silicone copolymer with 0.5% vinyl side chains, 2,4-dichlorobenzoyl peroxide as an initiator, and a silica filler obtained from burning methylsilanes. The platinum salt is used as a catalyst in the heat cure vulcanizing silicones. The vulcanization or a cross-linking is by free radical addition polymerization, which results from a thermal decomposition of an initiator to form a free radical that cross-link the copolymer into the three-dimensional resilient structure. Because of this, we will see the no byproducts. The processing temperature is about 180 degree to 220 degrees Celsius for 30 minutes under pressure using metal molds. The copolymers is supplied as a rubbery solid with a high viscosity. The pigments are incorporated into the polymer with roller millers. The Silastic PDM silicones and Q7435 is also the examples of the HDB. The advantage of this material, it is excellent tear strength and highest tensile strength at 5.85 megapascal, while excellent thermal, color, and chemical stability. It has a high percentage elongation. While the disadvantage of this material is that poor aesthetics due to opacity, less elasticity, less edge strength, and technique sensitive. The Silastic 370, 372, 73, 445, 14, 445, 15. These materials are white opaque material, highly viscous, dichlorobenzoyl peroxide or platinum salt as a catalyst, and filler is silica. The advantage of this material is it has an excellent thermal stability, color stability, biologically inert. The disadvantage of this material is it is less elastic, low edge strength, opaque and lifeless, difficult to color extrinsically and requires metal molds. The PDM silicones, which was discovered by Lons and Schwann, Adelby evaluated the properties of these PDM silicones. While the Q74635, Q74650, Q74735, SE4524U, these are the new generation which was evaluated by the Bell, and all these materials are single component system which are unlimited shelf life. In generally, all these properties, these are the a bit of the chart which we can directly differentiate between the plasticized polyvinyl chloride, polyurethane, HTB and RTB, which was differentiated into the tensile strength, maximum percent elongation, and tear test and the dynamic modulus. The recent advances of the maxillofacial materials is that silicone block copolymers, which incorporates the polymethyl methacrylate into siloxane blocks, more tear strength, improved wettability, and tissue compatibility. While the polyphosphazines, it was developed as a resilient denture liner, also used for implant denture retention and stability, and it gives the freedom of movement in the maxillofacial prosthesis materials. The foaming silicones, as the name suggested, it reduces the weight of the prosthesis by forming a sponge material. But the drawback of this material is that it is reduced in strength and susceptible to tearing, while the weakening of the material is also seen. The cyphenylens, it is biocompatible, resistance to degradation on exposure to UV light and heat, and improved edge strength and colorability. While the summary of this maxillofacial material part is that the various materials we can use it, but the fabrication of maxillofacial prosthesis, the material should be selected according to the type and location of the defect, patient's condition, cost, durability, and biocompatibility of the skill operator. These are some of the references which you can use it for your exam point of view. Now we will move towards the retentive aids in maxillofacial prosthodontics. The content where we are going to see is the introduction, classification, intraoral retention, extraoral retention, summary, and the references. In the introduction, the success of prosthesis depends on the method of attaching the artificial substitute securely to its place without any discomfort or irritation. Thorough evaluation of the defective site is of a prime importance in proper restoration of the prosthesis. The retentive areas are to be identified and recorded so that they can be utilized to the fullest. The types of maxillofacial prosthesis are the intraoral maxillofacial prosthesis and the extraoral maxillofacial prosthesis. The retention, according to it, these are again divided into the intraoral retention and the extraoral retention. While the intraoral retention are again divided into adhesives, mechanical, anatomical, and implants. While the extraoral retention is again divided into anatomical, mechanical, implants, and adhesives. But the mechanical is again divided into the spectacles, magnets, and snap-on attachments. Firstly, we will see the intraoral retention. The retention, it is the resistance to the vertical displacement of the prosthesis. The anatomical retention, it is derived from the residual maxillary retention, that is teeth and alveolar ridge. Within the defect retention, that is the residual soft palate, residual hard palate, anterior nasal aperture, lateral scar band, and height of lateral wall. The teeth, the teeth, the number, position, and periodontal status of the remaining teeth are the most critical factors. The defect is small and the remaining teeth stable, the intracoronal retainers might be considered. If the defect is large and some or all of the remaining teeth are weak, the extracoronal retention should be used. If the remaining teeth are not parallel with the walls of the defect, and if the palatal surfaces of the teeth are not adequate, The guiding planes may be provided to resist the vertical displacement of the obturator and disengagement of the retentive clasps. Alveolar ridge. Factors contributing to acceptable retention of a conventional complete denture, that is utilization of a physical properties of adhesion, cohesion, atmospheric pressure and interfacial surface tension. The ridge size and shape influence the retention to a certain extent. A large ridge with a broad ridge crest is more retentive than is a small or a tapering ridge crest. The palatal contours influences the ability to increase or decrease the interfacial surface tension. A broad flat palate is more retentive than the high tapering palate. A square arch form is more retentive than the tapering or a ovoid arch form. The residual soft palate, it provides a posterior palatal seal which minimizes the passage of a foods and liquid above the obturator processes and provides the retention. The residual hard palate, depending upon the location of the line of the palatal resection, there will be a varied degrees of undercuts along this line into the nasal or paranasal cavity. The prosthesis should thus be extended to provide a resistance to vertical and horizontal displacement. However, the extension should not contact the septum or the turbinates. Anterior nasal aperture. It may be extended unilaterally or bilaterally depending upon the extent of the defect to or beyond the midline and upon the presence or absence of the nasal septum. Lateral scar bands. Scar band results after the surgical resection at about the level of mucobuccal fold. As the scar band organizes, the contracts in the manner of a purse string, thus creating an undercut superiorly and concavity inferiorly. The scar band is flexible and permits the prosthesis to be inserted but will tend to resist the dislodging forces. Height of the lateral wall. It provides the indirect retention. High lateral walls of an obturator will undergo less vertical displacement with a given defect wall than will a shorter prosthesis lateral wall. The pre-surgical consideration, we are supposed to consider first the maintain as much hard palate, teeth or residual ridge as possible. Skin graft to the maxillary sinus wall. Remove the inferior turbinates. Skin graft the cheek flap and premaxilla should be preserved if possible. If the resection extends towards the soft palate and coronoid process should also be removed. The palatal mucosa should be preserved so that it can be used to cover the exposed bony margins of the palatal vault. This is the thing where we can consider how we are supposed to consider all the pre-surgical conditions. Now the mechanical retention. The temporary retention, where the stainless steel wire clasp is used when a sufficient sound teeth are present, usually on the both side. Bone screw retention, used in the edentulous mouth with sufficient hard palate. 13 to 16 self-tapping screw should be used to ensure enough length to pass through the denture and achieve adequate bone retention. The circumzygomatic wire retention. Wires are passed over the zygomatic arch and threaded through two bilateral holes placed in the premolar region of the base plate flange. The suture retention to avoid the screw retention and when sufficient hard palate is not present. Used in previously irradiated patients. Permanent retention. Cast clasp. Most common and successful technique when teeth are present. Variety of clasp designs are available. Attachments. The precision or snap-on attachments better for aesthetic purpose. The bars are generally used in combination with the retentive means like clasp or attachments. Overlay crown and thimble crown used when an overlay denture is planned or when any malpose teeth is used for retention. Magnets, these are magnetized rod or discs. Swing lock device used when loose or periodontically compromised teeth are used or severe inclination of the teeth are present. Implants that we will see it in detail. Adhesives, the denture adhesives can also be used. That also we will see it in detail. And the combinations of the implants and the adhesives. Extraoral retention. Adhesives, mechanical, anatomical, and implant. These are the types of the extraoral retentions. First, we will go with the adhesives. The criteria for selection of the adhesives is that the strength of the adhesive bond to skin and prosthesis material. Different adhesives have different bond strength. Udgama has found that acrylic resin adhesives are best in terms of bond strength. It should be biocompatible. How we will check it with the help of the patch test. Then the type and quality of the skin, that also we are supposed to consider it. The skin that is thin, friable and irradiated is not suitable for using the adhesive material. The types of adhesives. The acrylic resin adhesives, silicone adhesives, pressure sensitive types, rubber based liquid adhesives. Acrylic resin adhesives. Acrylic resin adhesives, these are the dispersed in water solvent. The examples are the Prosade adhesives and the Darrow adhesives. We will see the difference in the Prosade adhesive and the Darrow adhesives. The Prosade original was found to be difficult in removing from skin. Hence Pro 2, that is Pro Adhesive Aid Adhesive 2 was introduced. It is used or applied with the cotton tipped applicator, allowed to dry until it gets clear. Then second layer is applied and left for 1 to 10 minutes. Removed with the cotton moisture with the alcohol. The dry adhesives, that is epithene 3, it is also an emulsion of an acrylic polymer in water. It is white watery liquid applied with a cotton tipped applicator. On setting, it becomes clear and should not be allowed to set on an elevation present on the tissue surface of the prosthesis. Then the silicone adhesives. These are a form of room temperature vulcanizing silicones. The methyl triacetoxysiloxane cross-linking agent and the stannous octet used as a catalyst, while the fine silica is used as a filler. Once the adhesive is applied, solvent evaporates and key adhesive results. Develop the good resistance to moisture. It withstands the effect of sunlight, ozone, and chemicals. But the disadvantage of this material, it has a low strength. The Downey Corning 355 medical adhesive, it has a clear paintable liquid applied in thin layer and turns opaque after 1 to 2 minutes. But the drawback of this material is that the patient finds it difficult to remove from the skin and prosthesis. The application is tricky as it contains a fluorocarbon solvent, hence it gives a stinging occurs. Hollister Medical Adhesives and Secure Medical Adhesives, the Valpradate et al. In 1992 compared the mechanical properties of a PSA1 Dow Corning 355 Prosade adhesives and found that the Dow Corning 355 was superior in strength than other two. Then the pressure sensitive tips applied with a finger pressure in absence of heat and moisture. It consists of backing strip. It composed of cloth, paper or a laminate strip coated with adhesives. The adhesives is usually a rubber type elastomer combined with a liquid or a solid resin, plasticizers, fillers and antioxidants. It does not adhere well to silicone prosthesis, hence used in combination with the liquid adhesive. It is difficult to manipulate as sticky on both sides. Can be used for materials with poor flexibility and or in patients whose defects show little or no movement. The rubber-based liquid adhesives. The latex obtained from the tree bark is readily soluble in organic solvents like benzene or petroleum spirits, form a natural rubber adhesive. Example is barred appliance adhesive. The composition of this material or this adhesive is natural rubber, zinc oxide, titanium oxide, tachyfire, and N-hexane solvent. It comes as a white watery paste and starts setting immediately after extrusion from tube. 3 minutes for setting is completely required. It is opaque and sometimes visible through the margins of the prosthesis. Then the combinations of the above, where we can use acrylic resin adhesives and silicone adhesives. The prosthesis is coated with the acrylic resin adhesives and upon drying, the silicone adhesives is applied. Similarly, biphase tape is used with the silicone adhesives. Order is first we are supposed to use the silicone adhesive and then we are supposed to use the tape. It gives us the more improved bond strength. The technique of application of these adhesives is that it applied on the prosthesis with the help of brush or cotton stick applicator. We should left it for drying for 1 to 10 minutes, and on the setting the film becomes a clear or opaque and then applied on the skin. The Thomas suggested to apply in the center except for last 6 to 7 of the prosthesis. The adhesive remover, how we are supposed to use these adhesives. We can use 1:1 trichloroethane acetone spirit gum remover, specific remover supplied with the adhesives. The advantage of these adhesives are ease of application and manipulation, readily available, no need to undergo any surgical procedures, less expensive as compared to implants. The disadvantage of this material is that it may tear at the margins, routine removal may damage external pigmentation, patient with poor dexterity or coordination may have difficulty in applying. Some patient may develop allergic or irritative responses to adhesives. Then the mechanical. In the mechanical extraoral retention, we can use the strings bands by Ambrose Paré. Currently, we can use the eyeglasses, retentive clips, magnets, and acrylic buttons. The springs or bands, we can use it for the retention of the auricular prosthesis, while the acrylic buttons mainly used for the eye prosthesis. Eyeglasses. Whenever the patient is having a nasal prosthesis, moderately thick frames we are supposed to use it so that it will mask the prosthesis by using the eyeglasses. The advantage of this material is that the use of a frames of acrylic resin, opaque in color and retentive groove to be placed at the time of wax carving, though it is having a heavy prosthesis. In the orbital prosthesis also, we can use this eyeglasses for the extraoral retention. In the magnets used for over 20 years to retain the maxillofacial prosthesis, in the mid 1970s, the rare earth magnets were developed by with the help of the samarium, cobalt, neodymium with iron and boron. The indications of using the magnets where the areas of high muscle activity is present, moderate muscle activity with rigid prosthesis is required, or the patient is having a poor manual dexterity. The magnet, it is the most efficient means of providing combined prosthesis with retention and stability in patient with deformities requiring complex defect. The majority of prostheses with magnets are sectioned and have a magnet in each section. The challenge in magnets as retentive element depend on its ability to resist corrosion. The development of samarium iron nitride as magnetizable material may offer better corrosion resistance. The advantage of magnets have no moving parts to fatigue and break. It is self-seating, no damaging lateral forces to compromise abutments. The disadvantage of this material is that it has a corrosion, retentive becomes weak over a time. These are some of the Now we can proceed towards the implants. The placement of implants for retaining prosthesis depends on the number of factors such as the presence of bone, proximity of vital structures, the dexterity of the patient, soft tissue conditions, prognosis, patient's health, radiation therapy, and economic condition. The use of extraoral implants provide excellent support and retentive ability to improve aesthetics as well as the quality of the life. There are two systems available, that is solitary and grouped. In solitary system, the single implants are available, whereas in grouped, implants, grid or plate systems are present, which are secured by several screws. Extraoral implants with solitary systems are Brenmark system, ITI systems, IMZ system, ankylose system, southern implants, and EP implant system. Group implant systems are Epitech and Epiplating system. The features of extraoral implants. The surface modifications of extraoral implants are less diverse. These are comparatively shorter in length and have a dual structure with a endoosseous part and a thread in abutment. Generally, a perforated flange is provided to increase the implant surface area to have a more bone to implant contact, facilitate the initial immobilization and prevent undue intracranial pressure. The craniofacial implant classification, it is divided into alpha site, beta site and gamma site. The alpha site where we can use it if we are having a zygoma or anterior maxilla and mandible, where we can use 6 mm or greater diameter implant or the length implant. The beta sites is that we can use it in the temporal, zygomatic and anterior nasal fossa, where we can use the implant of 4 to 5 mm in length. The gamma site, we can use it in the zygomatic arch, medial orbit, temporal, frontal bone and zygomatico-frontal process. We can use the implant of 3 mm or less in diameter or length in that particular area. The surgical procedure for placement of extraoral implants and their abutments are similar to those for intraoral implants. The two additional procedures, however, are employed. The first occurs during the implant placement when the bone around the threaded implant hole is countersunk to accommodate the peripheral flange. The second occurs during the abutment placement when the surrounding subcutaneous tissues are reduced in thickness in an attempt to limit the mobility of a skin around the implant. If the skin around the implant is hair bearing, it may excised and replaced with a split thickness skin graft. The lack of hair follicles around the implant enhance the patient's ability to keep the implants clean. The restoration of implant may begin after adequate healing of the peri-implant tissues. The forms of the extraoral implants, these are in the form of V form, square, buttress and reverse buttress. The V form is more commonly used, while the square extraoral implants, it transmits the high compressive and low shear forces to bone, unsuitable for small implant length. The buttress area, it is more suitable for supporting the maxillofacial prosthesis, while the reverse buttress area, they are the thread form, can take care of the pull out force to a greater extent because the outward thread face is flat in that particular area of the extraoral implants. Place an extraoral implant, the fabrication of a surgical template is necessary or it is a prerequisite. It helps in pre-treatment planning by determining the oriental position and location of the implant. These surgical templates can be designed and fabricated either manually or digitally. The digital surgical template is advantageous over the manual surgical guide as it helps in pre and post-operative implant placement comparison. The various tools have been developed that the use of the surgeon with the digital planning of the extraoral implants. In the auricular prosthesis, the two implants are to be placed in the mastoid area 15 mm apart, keeping a distance of 20 mm from auditory canal opening. The right side, it should be at a 8 o'clock position and 11 o'clock position, while for the left side of the auricle, 1 o'clock position and 4 o'clock position. The retentive mechanisms used are bar and clip, ball clip, and magnetic retentive cap systems can be used. The healing period is 3 to 4 months. The nasal prosthesis. The primary site for implant placement are floor of the nose, piriform or inferior orbital foramen, and other site is glabella. The implant length is usually 4 mm or longer fixtures are used. 7 to 10 mm are used in case of supporting both intraoral and extraoral prosthesis. Such implants are called as a bifunctional implant as they support oral prosthesis at one end and extraoral prosthesis at the other end. The implant should be placed 8 to 10 mm apart in the anterior portion of the nasal floor so that it can be attached to immobile tissues. The healing period is 6 to 8 months. The retentive mechanism used are mini magnets and rarely by bar and clip. These are some of the nasal prosthesis where we can place the implant and where we can see the position. Okay. Then the orbital prosthesis, the location and placement of the implant. The outer canthus or inner canthus and superior orbital rib that we can use it for the orbital prosthesis. Additional implants or two was often placed in the inferior orbital rim or in the zygoma area. The implants should not be angled facially as it may interfere in the prosthesis contour. The length of the implant used is usually 3 to 4 mm. There should be 10 to 12 mm space between the implant to allow the access for hygiene, and most commonly used for retentive mechanism with implants are magnets. The healing period is usually 6 to 8 months. This is some of the diagrams where we can see the implants are placed in the outer canthus of the eye, and we have used the magnets and the bar clips for the retention purpose in the maxillofacial prosthesis. The surgical implant procedure. It is having again the one stage and the two-stage procedure. In single stage surgical procedure, the recovery screws are placed and the incision is closed in wire sutures, followed by dressing with ointment soaked with gauze to protect the skin. The two surgical processes are carried out in two-stage procedure. In the first stage, the first surgery deals with the implant placement into the planned location of a craniofacial defect. After sufficient healing period and osseointegration, the second stage is carried out. This procedure includes the subcutaneous tissue reduction, placing healing caps over the abutment, and gauze soaked in ointment is used to prevent a post-operative hematoma and swelling. From several studies conducted, it is found that the implant survival rate is high for a auricular prosthesis, followed by the nasal and orbital areas. The most common complication seen is peri-implantitis, which is related to hygiene maintenance around the implant site. So, the knowledge about the different method of retention of facial prosthesis is important in developing the proper design of the final prosthesis. If the prosthesis is improperly designed, it will fail clinically despite the best intentions of the clinician and patient. Extraoral implants are safe, reliable, and most effective method of retaining maxillofacial prosthesis with high survival rate, thus providing enhanced comfort for the patient and ease of maintenance is very important. These are some of the references which we can use it for the retentive aid in the prosthesis. Thank you so much everyone. Though this is a dry topic, I hope I have covered all the sections in the materials and the retentive aid in the maxillofacial prosthesis. Thank you everyone. Thank you so much.